First speaker is Dr. Boonprasit, the chairperson of this meeting, you know well. His topics will be about Engage trial. So, Dr. Boon, would you please start?
Yes, thank you very much. Thank you, Dr. Masuda, for the introduction. I would like to share with you this morning, I think one of the very long and outstanding results from the device that we are familiar with, the endurance stent graft. And we have the data up to 10 years now for the Engage. So this morning I would like to talk about what is the Engage registry and what lessons can we learn from this 10-year data from this study. And I would like to thank Medtronic for sharing this data with us so we can learn something, and hopefully we'll have some more discussion about that. We know that the reason that we treat AAA is to prevent rupture, to minimize second procedure. If we don't need to do it again, that would be great. And we need to we can prolong good quality of lives for our patients. To monitor that, we know that we have to have that we call successful AAA treatment. And not only successful, we would like to have durable, successful AAA treatment. To monitor our successful durability, we look at the mortality, right? We look at the endoleaks, we look at stent migration, device problem like limb kinking, limb occlusion and things. So we have the data from the Engage registry. Engage is used with the endurance stent graft. We know the parameters that we use for the Engage, for the AAA patients. These parameters, I'm sure you're familiar with that. But this registry is the real world registry. Means that it's all comers that the doctors treat, and then we will follow them, not only the good anatomy, but also with some hostile anatomy that were included in this registry. There are many hospitals from 6 continents, 30 countries, 79 hospitals, over 1,200 patients included in this Engage registry. And you can see it was outside the US, because when it started in March 2009, this device is not available in the US yet. So we have the privilege in our region to use it first. So in Asia, we have like Thailand, China, South Korea, and a few countries that included in this study. And our hospital also participate in this registry. As you can see here, that a few patients will have some challenging anatomies that will be more real-world experience kind of cases, not case in the RCT, and that will be more quite a standard anatomy that will have a better results. What I share with you today will be a short and long-term results. We look at the 1-year result, 5-year, and then eventually, this is the main purpose, look at the 10-year results that we have. I would like to include the 1 and 5 years for just a few of us may not familiar with the results from this. And again, we look at the successful treatment. Successful treatment, we look at the mortality should be lower, right? Not too high. Not few endoleaks, stent migration should be lower, and the device-related problem should also be lower. The 1-year data is already published. Many years ago, the Engage started 2009, complete 2011, and then they continued. The first plan was to follow up to 5 years, which is quite long enough at that time, 5 years. So at the first year, we can see that the endurance stent graft in this more than 1,200 patients, the all-cause mortality post-op, the very, very low, 1.3%, all comers, and conversion to open surgery was also very low. Also low secondary surgical procedure, and also almost non-existent of the aneurysm rupture in the first year. So good short-term result. And we can see here that the excellent survival up to 1 year for this patient is very, very good. Also with the secondary, free from secondary procedure is very, very high. At 1 year, excellent result, but that's as expected, right? 1 year, everything is fine. And what about longer term results? Will the low mortality, the low problem with the migration, and the limb occlusion will continue to be good? that is something that we have to follow our patients. Will we get a good aneurysm sac shrinkage at a higher percentage of our patients? That is something that we continue to look for, and that will be answered at the ENGAGE 5 years. And this also already published 4 years ago, 2019, and you can look at that in this result. I will summarize, just short summary for you. What we can see, where we can learn from the 5 years data from the ENGAGE is that the mortality, the all-cause mortality is continue to do well. I put the others, 52, 68, 72. There are a few other studies. You can see that the mortality, the survival-wise is quite reasonable, quite well, quite good. And when we look at the free from secondary endovascular procedures, also high, up to 84% at 5 years, is maybe more favorable from the other study reported at the range of 5 years results. When we look at the problems that we always look at when we follow our patients, is that the main body migration, you can see here, the main body migration is at up to 5 years is 0.3% at 4 years and 0.3 at 5 years. Very, very low, actually surprisingly low migration rate for in this kind of hostile anatomy included. And endoleak was also not that high, 10%, around 10% up to 5 years. And majority of those endoleak will be type 2 endoleak. Of the 10%, 8%, 8 out of 10 will be type 2 endoleak. So that is another issue we will talk later today. And proximal endoleak, of course, it happened. And it happened, but not that high, up around, let's say, roughly about 1%. And so the result at 5 years, quite promising. And when we look at the aneurysm shrinkage, and you can see that here, that the aneurysm shrinkage rate at the blue, turn up blue, I put it purple and blue quite the same, right? Okay. The shrinkage rate is quite high, up to 60%, almost 2/3 of the patient, our aneurysm patient, aneurysm shrink at 5 years. And the other study may be around 40-50%. And the aneurysm, of course, there will be some failure when the disease kind of progress in some patients. The question is, at 5 years, we have data that the endurance give us a low aneurysm mortality, give us low rates of endoleak, stent migration, reintervention, and high aneurysm shrinkage rate, up to 2/3 of the patients. Now we have 1 year, 5 years. The question is, what if after 5 years? Do we have longer term, maybe 10 years? Will the results continue to be good, or everything will crumble down? We'll have some problem after 5 years. So thanks to Medtronic that they continue to have this study extend more. And so actually the first plan was 5 years. So they have to extend the study. Not every hospital, you see in the first few slides that 79 hospitals, not everyone participate, but there will be 49 patients agree to continue to study. Will be around 1,000 patients. During the past 5 years, some patients died, some lost to follow-up, and so there will be about 608 patients available. And those, when we do the follow-up, there will be these old patients, right? There will be more mortalities and more patients who are confused to come back for follow-up every year for another 5 years to 10 years. So we end up having almost 400 patients from the first group that we included almost 5 or 6 to now, 10 years ago. So when we look at the group that we look at the extended group here, the extended cohort compared to the previous one up to 5 years and not extended, are they the same group? Actually, what we can see that's quite interesting is that the case that have 5, 6 to 10 years follow-up, they tend to be a bit younger. They tend to be less cardiac disease, less lung disease, better kidney, less stroke and less peripheral vascular disease. So it's understandable because these are younger patients, so they survive up to 10 years. They don't die from other causes yet. But remember that these patients have very low aneurysm-related issue. So they continue to survive. And when we look at the procedure characteristic, maybe the anatomy may be a little bit easier, more straightforward to begin with. So these patients will be able to live longer. So that is one point to look at. But when we look at the first 5 years, this is the first 5 years, and then the extended 6 to 10 years, you can see that the survival is quite reasonable, quite good, up to 10 years, 42%, 43% survival. So that is quite reassuring for us that this device will give us quite a durable result for us. What about the secondary, the freedom from aneurysm-related mortality? 95% freedom from aneurysm-related mortality up to 10 years. And that is excellent results that we can get for the treatment, for the stent graft. And 70%, yeah. And why it failed, why we need to do the secondary procedure, we have some details. And I think this is something that we can learn, so we can prevent it from happening again in the future if we can. So most of the early reintervention in the first 5 years, mostly will be because of the type 1. The type 2 is the most common, and then the graft occlusion. So these are the problems that we may see in the beginning, first 5 years. What about the second 5 years, 6 to 10 years? And you can see that the limb graft occlusion was not a big issue now. Type 2 is still the problem. But we will see the degeneration of the anatomy of aorta. So it's not surprising that we may see more type 1 proximal and distal endoleak. I think one thing is the degeneration of the aortic anatomy. What about the endoleaks? And as shown here, that the majority of the endoleak in the beginning, first 5 years will be type 2 endoleak, but the type 2 endoleak is still the main problems that we have to deal with, and what we will learn again more later today, tomorrow. And the same message, there may be some degeneration. We have the type 1A, the darker blue, and the light blue will be the type 1 distal endoleak. There will be an issue in the future because I believe that some of those, majority of those will be the degeneration of the anatomy. And type 3 and type 4 will be a bit, not that high, but we may see it after we follow the patients quite long. So what we learn is that we have 43 patients, 43%, that 19 of them, 43% of the 43, has some problem. But look at this, almost half of the late failure, type 1 endoleak, the patient has wide neck to begin with. Will have short neck to begin with. And for some reason, the oversize is not enough. So if we can fix this, we may be able to prevent almost half of the failure in the next 10 years. So the failure rate will be even lower if we understand about the failure that we have. So this is the good learning from the study. And again, the main body migration, look at this, is very low, even up to 10 years. You see this is, the incidence is 1%, 1.5%, 2%. After the first 5 years, almost not an event, not an issue. After 5 years, there may be some, but not that high. It's not zero, but not that high. We still be able to fix it. And also with the graft occlusion, maybe the more common in the first year, but then after that, it's not an issue, not a big issue for us to concern about. And ruptured aneurysm, not that high. The highest will be after 8-9 years, and still not very high. But the failure of the rupture mostly will be from the again the proximal sealing zone that we have. And so the late aneurysm rupture will be mostly from those type 1A, type 1B. And so if we can prevent that from the beginning, we don't treat too short too wide, oversized enough, maybe we can prevent even more. What about the aneurysm sac shrinkage? What we learned is that the aneurysm shrinkage continue to do well. Up to 10 years, 65% of the patients have aneurysm shrink more than 5 millimeters. And of course, those with the aneurysm sac enlarged over time because of some failure. As I mentioned before, we will see maybe more of the sac enlargement because of the migration, because of some other endoleak, something happened. But what reassures us is that 2/3 of the patients' aneurysm shrinkage continue to be that way up to 10 years at least, and not many patients that we treat will live up to 10 years anyway, and majority of them will do well, and we don't need to do anything much. And again, if we can fix that 3 issues, I think we will be able to get that. I don't touch this much. I'm sure Dr. Chong would mention about this. Sac regression is something we would like to have. Sac regression is not the same as sac stable. It's better, and we would like sac regression. Endurance will provide us over 60% sac regression over up to 10 years. So it's better survival with the sac shrinkage. And if we can deal with this problem, we hope that we can deal with the wide neck, short neck, oversizing, and some other factors. We may decrease that pink line. We can get even better results. So what we learned from ENGAGE 10 years data, it confirmed that our long-term efficacy, durability of the endurance stent graft is quite very good, and 94-95% free from aneurysm-related mortality with no decline at longer follow-up. 70% free from re-intervention rate up to 10 years with no decline at longer follow-up, and a consistent more than 60 degrees sac regression. And this is the most frequent cause of the late adverse event associated with the hostile anatomy. That is something we will discuss later today, how we can do it better than when we do it 10 years ago. And hopefully we will be able to get even better results. And what we learned is that lifelong surveillance is still critical, but we can modify it because we know that aneurysm shrinkage patients, they're doing better. Some limitation though, because because of the consent, have to reconsent. Some patients do not continue, so we miss some data from some patients. And the group that we follow 6 to 10 years, those seems to be healthier compared to the whole group. And this is the observational registry, only single arm. So in conclusions, Mr. Chairman, I believe that the endurance, we have shown that the ENGAGE registry using the endurance stent graft up to 10 years. It demonstrates better survival, low secondary intervention procedures, low incidence of endoleak, particularly proximal endoleak and device migration, and high percentage of aneurysm sac regression, more than 60%. And that may change follow-up strategy, I guess, for those sac shrinkage. We may not need to follow them that closely, like CT scan or ultrasound every year. We may do it every other year or every 3 years, something like that. Something that we have to consider. With this, it will help with a better survival, and it may change if we can even get better result if we deal with the wide neck, short neck, or oversizing and other options that we may have. And sac regression sac regression patients had better survival compared to those with stable sac. So we don't expect for only stable sac. We want to see the sac shrinkage when we put the stent graft in for our patients. And the endurance stent graft provides excellent long-term results in the real-world AAA patients. And this is the data that we can learn from the ENGAGE registry. Thank you very much for your attention.
Thank you very much. Very nice review of the ENGAGE trial and very new. Thank you for your very informative new information. I would like to ask about a very big picture. In EVA1 trial, very early stage of open and registry data reported no difference between the endo and open. However, I think that all stent grafts has been improved after that, and might be other data, maybe better result in the long term with EVA might be reported in the near future. How do you think about that?
Yes, I believe that the device is getting better, and actually the device we have now is good already, I guess. And I myself, but this is my opinion, is that if I have aneurysm right now, I still consider I'm a little bit young. I would have a stent graft. I won't have open repair, and I believe that if my anatomy is not that challenging, I think we have enough data to confirm us, to reassure us that if we put a stent graft in, particularly with the data we have from the endurance, from the ENGAGE registry, it will provide me at least another 10 years easily without any major problems for the results. I'm not sure we will have the new design will be better device coming out. I'm sure that it will be even better, or maybe some additional adjunct procedure with the endurance, with something that we just talk about, endo anchor or some other thing, maybe even provide us even better results, I guess.
Yes, from long-term results, we have already knew or found something I don't know. We have two panelists there, and do you have any questions?
Yes, sir. Thank you very much, Professor Masuda. Dr. Boonprasit, how about the outcome of Asian population? You mentioned that the ENGAGE trial consists of 6 continents divided into Asian and non-Asian. I was wondering about the Asian population. As we know that right now the anatomy of aneurysm is different between Asia and non-Asia population. So I would like to know about the outcome, especially long-term outcomes in ENGAGE trial between Asia and non-Asian population.
Thank you very much. I think actually ENGAGE has already this data at 5 years came out not that difference. I asked them about the result in angulated neck because there are some patients in ENGAGE registry has some severe angle neck more than 75 degrees. Was there any problem, a higher incidence of endoleak or migration? They look at the data and found out that it's no difference. The problem related with the endoleak or migration mostly will be because of the wide neck and short neck and oversizing, only 3 factors. Angle neck is not an issue yet. I'm not sure because of it's really not an issue or the number is not that high. So we may need to look at that. We may ask Medtronic to look at only data for Asian up to 10 years. We haven't seen that one yet, or maybe they have it, but I don't know that one yet. But as far as I know from in the past, no difference.
All right. Dr. Chon, do you have some comments?
Good morning,
or
everybody.
questions?
Thanks, Dr. Boonprasit, for sharing the impressive results for the ENGAGE 10-year data. As I think about it, it seems that the device itself, Medtronic has a very good device, low migration rates, low endoleak rates. So I wonder how the new device will make things better, one. And then secondly is, in terms of to get better results, maybe it's not just device innovation, but rather for implanters like us, how to choose the appropriate patient so we don't get long-term failures rather than just device modification. But thank you very much.